Thank you so much for introducing me. I had around 1 minute ready to introduce myself, but that was covered. Thank you so much. So my name is Seyed Ali Safizadeh. I'm a fourth-year medical student at Mohammed bin Rashid University. And my research is about the genomic overlap of neurodevelopmental disorders and congenital heart defects. So I did this research with my professor, Dr. Mohammed Uddin. All right. So this is the outline. I'll just start with the background, then give the objectives of our research, talk about the methods that we used, the results we gained, and finally conclude, and give the future direction that we're going with this research. And it's important to mention that we've started this research for about a whole year, and we're still around halfway through, so we're not completely done. So just to introduce the topic, congenital heart defects are actually the most common birth defects found in neonates. And it's usually some structural defects in either the heart or the vessels. And the estimated prevalence is 8 per 1,000 live births. And this includes several types of defects, such as most importantly, septal defects. And causes can be environmental or genetic, and treatments are usually surgical procedures. So it's important to mention that children with congenital heart defects, when they undergo a surgical procedure and then come back to the clinic, doctors usually just look at their exercise tolerance and check if they have a normal sinus rhythm, and if everything is going fine, they usually don't consider following up the patient and think that the only issue with this patient with a congenital heart defect is the heart only. However, it's important to mention that as the patient ages, there are several other organs that come into play, and specifically the brain. So it's important to take into consideration the issues that arise with the brain. So this is where neurodevelopmental disorders come into play, and around 10% of the congenital heart defect population develops some sort of neurodevelopmental disorder. And if the patient has a severe heart defect, then the percentage rises to around 50%. And the explanations include either some circulatory failure that induces a hypoxic insult to the brain, or some intervention that provided the stress to the brain. Now, this graph is to basically show that with the complexity of the congenital heart disease, the more severe the defect is, the higher the prevalence of neurodevelopmental disorder. So as you can see, it goes to approximately 50%. With very severe CHD. But it's not only the brain that's affected, there are also other systems that are affected, and most notably the genitourinary system, as well as the respiratory and GI system. And around 13.6% of CHD patients get to have another congenital anomaly. So mild CHD can be categorized into different diseases and defects. So including these defects are ASDs, atrial septal defects, VSDs, and stenotic valves, specifically the pulmonary and aortic valve. So the reason that these are called mild is because there's no urgent intervention that's required to these patients when they're born. So usually ASD, the patient can survive to around 3 to 5 years, and that's the time period that usually some sort of intervention and surgical procedure is done to close the defect. And as for VSD, usually earlier age, some months, 6 to 8 months is when an intervention is done. So there's no immediate open heart surgery that's required or any cardiopulmonary bypass. And as for the stenosis, usually a balloon is inserted at a later age. So moderate congenital heart diseases are either atrioventricular septal defect where there's no atrioventricular septum, and then tetralogy of Fallot. So in this case, a patch is inserted to separate the heart into left and right chambers. And this is done at an earlier age compared to the mild congenital heart defects. So around 6 to 8 months is when some sort of intervention is done. And these are usually complex repairs compared to the previous ones. And there is some sort of hemodynamic compromise. And then we have the severe congenital heart defects, the transposition of great arteries and interrupted aortic arch. Again, these are the most severe, so this is where the patient most likely gets an hypoxemic insult to the brain and has a higher chance of developing neurodevelopmental disorders later on in life. So I won't go through this in detail, but these are some risk factors for developing NDDs later on in life. And it's mostly patients that required open heart surgery, or had cyanotic heart lesions, or were premature. So this is a test that's done to usually in autism centers for autistic patients. And this test has been done on people with congenital heart defects. And I'll get to a graph later that states where these patients stand in, but I just want to ask you, which one do you think is the correct answer? Which one of these four is this patient? If you look at his eyes, which one do you think it is? Okay, insisting. Any other suggestions? Cautious. All right. So yes, the correct answer is cautious. And when this test was done on patients with CHD, patients with tetralogy of Fallot or transposition of the great arteries usually scored lower on this test. So neurodevelopmental disorders, the effects of this come on later in life, and it's been shown that these patients tend to have decreased employability, usually tend to be more independent and can't form very good relationships, and overall their quality of life is reduced. So genetic disorders of the heart and brain, it has been shown that syndromes also have a role to play, and among 1/3 of CHDs are caused by genetic abnormalities. And among these, we have trisomy 21 and the George syndrome, the George being a microdeletion and trisomy 21 aneuploidy. So this introduction was just to say that the phenotypic relation has been well studied. However, the genotypic relationship between these two disorders hasn't been well studied yet. So this is where our team stepped in. So copy number variations, I'm sure most of you know what it is. Just a brief overview. It can either be split into deletions, duplications, or inversions, and usually detected by chromosomal microarrays. And they have been found to be major risk factors for these two disorders. And these are split into benign variants, which are not clinically significant, and pathogenic, which most likely have a correlation with the disease. And variants of uncertain significance are ones that we're still not sure whether they're actually pathogenic or not. So objectives of our study were to investigate the genomic overlap and find the significant gene list between these two disorders and find out the most significant pathways that are basically involved with these genes, especially the deleted pathogenic genes, which I'll talk about later on. And we also wanted to identify single cells that most likely express these genes. So our methods, we have a very large cohort from 2 hospitals in Ontario, Canada, and from these we have around 14,000 cases that we collected. And so around 9,000 from Sick Kids Hospital, and Credit Valley Hospital around 5,000 cases. So in total, we can say that we had 11,000 neurodevelopmental disorder cases and around 3,000 congenital heart disorder cases. So all these patients underwent clinical microarray, and they came into the hospital with a suspicion of these disorders, and that's why they underwent microarray testing. So using the circular binary segmentation algorithm, these genes, the genes were, and the CNVs were split into either de novo, which were validated if the parent had not had the gene, or the rare subtype. And then a clinical cytogeneticist, through the ACMG guidelines, annotated these CNVs. And it's important to mention that we removed CNVs larger than 10 million bases, 10 megabases. And then the genes were split into duplicated, deleted, and we further subset these in between these two disorders. So we use controls to exclude the polymorphic cases, and we had around 10,000 high-resolution controls that were basically patients with no psychiatric history. And we collected them from a couple of major population scale data. So pathway enrichment was done on these, as well as some preliminary single-cell analysis. So we have around 5,000 neurodevelopmental disorder cases that are VUS, and around 600 to 700 of pathogenic, and a smaller number for CHD cases. So pathogenic variants tend to be larger in size, so that's why they tend to be smaller in number. And VUS are usually shorter in size, that's why we tend to have more of them. And these are the de novo cases which we're most interested in analyzing, and we have around 210 cases. So the significant overlap genes between the gain pathogenic, which is the duplicated pathogenic genes, there are around 273 overlapped, and the odds ratio is around 2.9. And this is the most significant result that we had with the lost pathogenic. And the reason being that the odds ratio here is 7.4%. And what this means is that we're most likely that this is a true number. And there's a true correlation because some genes tend to be haploinsufficient. So if there's one deletion, then in one allele basically, then the gene tends to, the protein that results from the gene tends to be non-functional. And the loss VUS 277, odds ratio of 2.1, and the gain VUS. So duplications are a bit complex to study because sometimes they act as deletions because of, they can either have no functional dosage or increase the functional dosage. So it's a bit tricky to study duplications compared to deletions. So one candidate gene that we found was the CLSTN1 gene. We think that, so basically it plays a role in axonal anterograde transport. Some of you are familiar with the kinesin 1 protein here. So this is most likely a plasma membrane transprotein that mediates these axonal transports. And it's been shown that it has a role to play with the amyloid protein precursor protein transport. And again, it's most likely to be found on the plasma membrane. So we did pathway enrichment analysis, and we found that the pathway with the highest odds ratio was the extracellular matrix organization regulation pathway, as well as several others. And so we did network analysis, and this is just two graphs that we made using Cytoscape. So the red nodes, as you can see here, are the ones with the lowest p-values and the highest significance. So we found the forebrain neurogenesis pathway and the serotonin kinase activity pathway to be expressing these genes. And the single cell analysis, the preliminary analysis that we did, demonstrated that neurons were the highest cells expressing these genes, as well as astrocytes and endothelial cells. So we did identify significant overlap between pathogenic and VUS CNVs found both in congenital heart defects and neurodevelopmental disorders. And just to recap, we did find that neurons, astrocytes, endothelial cells were the cells to be having the highest expression of these genes. And so in the near future, we just want to, because this was a preliminary single cell analysis, we would like to have a larger transcriptome data to conduct this analysis and to validate some of these genes and characterize them, possibly using the CRISPR technique. And if these genes can be further studied, then this is a whole new area for precision medicine to take hold of. I just want to thank these people, Dr. Mohammed Uddin, Professor Alawi, our Dean and Provost, as well as my dear friend Abdurrahman Ali and Samana for their help. And thank you so much.